evening, everybody. My name is Debbie Sokoler. I'm the Vice Chair of the Board of Jewish Family Services, and I want to welcome you tonight to our next Preparation Age program. And so happy that you're all here to join us. Tonight's program is Prepare to Maintain Health and Wellness. Tonight, we'll learn about age-related health concerns, including managing a chronic illness, basic exercise, diet, and wellness. We'll understand various health offerings for those 65 and plus, including Medicare and insurance sign-up assistance. Tonight's speakers will be Dr. Michael Wolff, internist and geriatrician from the Community Care Physicians, and Jane Sanders, LMSW, former executive director of the Bethlehem Senior Services. As we get started, we did want to remind you of a few of Zoom's features. First, please use our chat to say hello and ask questions of our presenters. Send in your questions throughout the presentation, and we'll do our best to get to all of them once the presenter is finished. Also, it is so nice to see your faces on the call this evening, but just a reminder that if you have your camera on, other participants can see as well. So be mindful of what you want to show us. Our first presenter is Dr. Michael Wolff. Dr. Wolff is board certified in internal and geriatric medicine. Dr. Wolff served his internship and residency in internal medicine at Beth Israel Hospital as a clinical fellow of Harvard Medical School. His specialty lies in the practice of adult medicine, concentrating on the care of the elderly. He's proud to care for 4 generations of a number of families. Dr. Wolff is a clinical associate professor of medicine at Albany Medical College, where he was the founding program director of the Fellowship in Geriatric Medicine, funded by the Eddy Endowment. He is also a senior fellow of the Alden March Bioethics Institute and a public service professor at the University at Albany. Dr. Wolff has been involved with numerous research projects involving Alzheimer's disease, quality initiatives and long-term care, and health delivery systems for the elderly. Dr. Wolff has been a medical director for long-term care and rehabilitation and serves as the director of geriatric services for the Capital Healthcare Association and Community Care Physicians. Thank you, Dr. Wolff, for joining us tonight, and I pass the Zoom on to you.
Thank you. Thanks, Debbie. Nice. Thanks for the nice introduction. Hello, folks. Thanks for joining us. And I'll try to spend 20 minutes or a little bit less talking about a few items, and then hopefully there'll be some time for questions. You may hear a choir singing in the background because I have to go from here to a choral rehearsal. And if you see my interesting closet, it's actually a music storage room at SUNY Albany. So lots of busy times right now. You can see the slide, I think. It says age-related health concerns and managing chronic illnesses. And go on to the next slide, please. Thanks a lot, Kara. It'll be a brief presentation. I want to talk a little bit about prevention, a little bit about listening to our bodies, and I'm among the elders nowadays, and about age-associated illnesses, and then a little bit of philosophy about what it's all about. Obviously, this is a very, very heavy, large agenda. It'll be an overview. So there'll be some time for questions. Next slide, please. The best method for longevity and good health is to choose your grandparents carefully. Next slide. But if you neglect to do that, the best thing is to keep active both mentally and physically, and to try to avoid fads. Next slide, please. And I'm going to concentrate here a little bit on physical aspects, mental aspects. Keep engaged. Puzzles maybe help, but really engagement is the key. But in terms of keeping fit, really the best preventative for many things is to maintain cardiovascular fitness. But listening to your body also means maybe not running a marathon, but instead maybe jogging a little less distance on a soft surface, or walking instead, or bicycling, or using an exercise machine instead of running. It's important to stretch, to use warming before activity and icing after. You might want to consider compromising the length of your workouts. It's important to have adequate rest. I always remember an old Runner's World article which said, don't exercise 7 days a week, exercise 6. Now, personally, I violate that. But you do have to see, if you start aching, if you start doing the same thing every day, you may have some overuse injuries. So you need to think about varying your workout. Lighter meals are important because metabolism tends to slow down. And less alcohol is a good idea because we all tend to metabolize many things, including alcohol, a little less efficiently as we grow older. Next slide, please. On to prevention. Let's talk about immunizations a minute. We all know about flu shots. They vary every year. They're about 50% effective. Pneumococcal pneumonia vaccinations have changed recently. Prevnar 20 is now the standard. Many of us have had Pneumovax previously or Prevnar 13. The combinations depend on when you get your vaccine, how old you were when you got them, and what the recommendations are. And every year, CDC puts out new adult immunization recommendations. So these things do change. But if you haven't had pneumococcal vaccination, the likely one you will be given will be a Prevnar 20 now. Tetanus, diphtheria, and pertussis should be boosted every 10 years. There are still occasional tetanus episodes in this country, typically 8 to 10 a year. Not many, but a few. Diphtheria is rare nowadays, but there are under-immunized populations, and that is particularly so for pertussis. We continue to see pertussis in under-immunized children, and these tend to go home and get into the community. So this particular booster is important, and it's particularly important if you are associated with school-aged children or grandchildren or even great-grandchildren. Herpes zoster immunizations, this is shingles, have evolved. There was an old one called Zostavax. There's a more effective one called Shingrix, which is a two-step vaccine. It is associated with some reaction, especially after the second one, but is highly effective in preventing shingles. And the purpose of that is to prevent pain after shingles, but also to prevent corneal scarring, which can occur, involves the eye. And then there's COVID-19, and we all are aware of the boosters, which are being strongly encouraged. And the next slide actually isn't of COVID-19, but this is flu. Dark blue is epidemic levels. This is this past week's New York State epidemic map. Dark blue is epidemic. We're about 6 weeks ahead of where we ought to be. And the reason I show this is the following. As I said, flu vaccinations are about 50% effective, but with those vaccinations and effective antivirals for flu, even though we're seeing a lot of it, the rate of death in the United States has come down per year from typically somewhere between 35 and 80,000 to somewhere between 10 and 20,000 a year. Now, we're likely to end up in a very similar place with COVID because viruses change, and we've heard about this in the press and on the radio and TV. What happens is that as viruses mutate, technology tries to keep up with them with vaccinations. So we are going to be in annual vaccination mode. Is going to continue. COVID is likely to be in our future forever, certainly while we're all alive. And the vaccinations will be imperfect, just as influenza vaccinations are imperfect. But just as the likelihood of death from influenza is about half or even less what it used to be, similarly, if we keep up with the COVID changes in terms of vaccinations and getting vaccinated, we're likely to see similarly impressive reductions in death rates from COVID. So this is a reason not to say, oh, to hell with it. We've been there, we've done that. This is what our future will also look like for COVID. We need to keep up with the newer immunizations as they become available. Next slide, please. So on to some other prevention, annual screenings, colon cancer, some form of of screening is better than none. Most of these for screenings stop at 75, but at the upper part of the slide, you see versus surveillance. Surveillance is something different than screening. If you've had a polyp, if you've had a cancer, if you have a first-degree relative who has polyps or cancers, the same age limit may not apply. The age limit may, instead of 75, be 83, or it might even be later if you are physically well. So something to consider and discuss with your physician or nurse practitioner or PA. Mammography. Most people agree that there may be more harm than good in doing mammography after age 80. Again, there are exceptions. If somebody's had breast cancer, has a first-degree relative with breast cancer, and there may be a personal preference difference here. Pap smears have age limits. Generally, after age 65, they aren't considered necessary, but if somebody has had abnormals, if they've had cancer of the cervix, if they have HPV, human papillomavirus, the need for a pap smear may extend a little later. PSA clearly has more harm than good associated with it after age 70 because it's not a great test. Its signal to noise ratio, so-called, is not very good. So it can cause more morbidity because there are false positives as people get older. They end up having biopsies that aren't needed. There's some debate as to whether it should be used at all past 65, but after age 70, in general, it's not a good test. Cholesterol is another issue as people get older. There was a movement of say, listen, let's forget about cholesterol as people get older. They've lived their lives. These drugs, the statins, were created for younger people by and large to prevent first or second heart attack. On the other hand, there is evidence that as people get older, the statins do still have preventative benefit as far as heart disease and stroke are concerned. So it's not a settled issue. And again, individualized care discussion with your provider is very important. And finally, in this list, blood pressure goals do change a bit as people get older. The general agreement is less than 140 systolic, less than 90 diastolic is preferred. There are exceptions though, and those exceptions tend to arise more if people become frail as they age and if they tend to get lightheaded on medicine. So there are exceptions, but the goals really have tightened a bit over the years because the outcomes are better with more stringent treatment, but that must be tempered by caution with respect to such things as dizziness or what is called postural hypotension. Next, please. So I'm going to touch very briefly on age-related illnesses. And these, the various listings, this is sort of a modification of something called the giants of geriatrics. First of all is med interactions and dose sensitivities. The goal, the point is to go low and go slow with medications. Be slow to introduce them, start with low doses, increase the doses gradually, and consider what the last item in that first bullet is med diagnosis interactions. If somebody has problems with constipation or with their prostate, if you give them an antihistamine for their allergies, you're likely to make those problems worse. If somebody has some forgetfulness, again, an antihistamine is likely to make that problem worse. And when I talk about medications, I include alcohol here, as I said earlier. Be mindful of dosing. Mood disturbances are very common in all age groups, but they are quite common in the elderly. There are depressions. There are things that cause depression. There are losses that are inherent in growing older and losing friends and family. Mood needs to be attended to and can be treated with careful dosing of antidepressants, but also equally important and at times of higher benefit is good counseling. And the combination together is more effective than one or the other. So both counseling and medication to be considered in late onset depression. Also, there are allergies. There are, again, substance use issues as people get older. Memory impairment is age associated. There's certain things that are normal though, And one that I commonly hear people worrying about is blocking. What did I come into the room for? What was I going to say in this lecture? What is that word? But the best way to remember something that you're blocking on is to forget it and come back to it 2 minutes later, or it'll come back to you at 2 a.m. when you wake up and say, oh yeah, that's the word I was looking for. But some of that is normal and really starts around age 30. But when memory loss starts to interfere with activities, whether it's things like taking your meds or finding your way to the grocery store, et cetera, then it becomes more serious. But the simple blocking, the little bit of cognitive and word finding difficulty that reverses itself quickly is not a real worry, but it takes a little bit of judgment to know which is which. Urinary incontinence is very common. There are medicines for it. The medications, with the exception of one, tend to be antihistamines, and they can cause mental slowing and constipation. So it's something to be aware of. There's one option which is not an antihistamine, but there also are Kegel exercises. They're non-medication related ways to deal with that. And then mobility impairment is a big deal because degenerative arthritis is clearly age-related and it's very common and is one of the principal disabling factors in old age. But I should say that the mobility impairments are shifting to older age groups as compared to 20 years ago. So there's some hope there. And exercise helps. Doing more, strengthening musculature is very helpful. Next slide, please. And then finally, what's it all about? And this is not an easy slide, but if you look late adulthood, 65 and above, this is Ericksonian material. Erickson talked about stages of life and what are the virtues, in this case, wisdom, what are the psychosocial crises, in this case, ego, integrity versus despair, who are the significant people one relates to, in this case, humankind, and what are the existential questions? Is it okay to have been me? And then the event is self-reflection. Was my life really worth living? What have I done of value? But I wanted to focus a little bit on ego integrity versus despair. And the thing with ego integrity, its greatest determinant really is the sense of autonomy. What can we control? What do we still have the power to influence in our immediate environment? And so if I, as an elder, say, I don't want that test, I need to be able to control that, okay? Or if I say, as an elder, I still want to live in my home, if it's possible to do so, it's important to my integrity as an individual who actually influences the world, in this case, my world, to have the autonomy to make those decisions. And this is one of the reasons that autonomy is so central to ethical decision making in medicine. I think Jane will address some of the tools that we can use to help enhance the autonomy of ourselves and of other elders who we may care for or be close to us, so that we can enhance the autonomy of those we love and ourselves. So with that, I'll open things up for questions. And I think, Monica, are you the moderator for this?
No, actually I am.
Debbie, hi.
Debbie. We have a couple of questions here. If someone has a family history of high cholesterol, what are other effective interventions aside from taking statins?
Well, first, diet. So care with fatty food intake, but that has limited benefit if there's a strong genetic component. Also, exercise can be helpful. So those two things to start with. There are some plant sterols, which are a little helpful. Some of these margarines, which have statin-like substances in them. Red yeast rice has some benefit. None of them have the potency of the statins. There are now injectable agents. They're very expensive. They seem to work not just for cholesterol, but there's beginning to be some scientific evidence that they may, in fact, help with arteriosclerosis. But those are generally reserved for people who have actual vascular disease. If you get to be into your 70s and 80s and you've not had vascular problems, again, this was where we get back to the debate as to how important is it to lower cholesterol, and some people believe it's not as important. But again, this is something that's a little open to debate still.
We have another participant who's actually asking a question that I was going to ask. So you get two of us. A person who has a lot of age-related issues, how does one identify a geriatric physician to look after them? I know that I had that problem with my mother downstate because it really is a specialty. Yeah,
well, there's the American Geriatric Society has a listing. The American Board of Internal Medicine and the American Academy of Family Practice also has listings of those who are board certified. You can ask your primary physician for recommendation, and they don't tend to know who is actually practicing. And, it depends on the setting too. At this point in my career, I just do outpatient work. There's some people who just do institutional work, either skilled nursing facilities or assisted living sites. So people do work in different settings. There are some insurance barriers to consultations because most insurance companies don't recognize geriatricians as having consultative status, even though it is considered a full subspecialty now of internal medicine. So there might be, particularly with capitated plans, sometimes there are insurance barriers. But I think if you ask either the Medical Society or American Board of Internal Medicine, American Academy of Family Practice, or American Geriatric Society, you're likely to get a name or two. So.
Thank you. And I guess we have time for just maybe one last question.
Yeah.
For vaccines such as shingles and pneumococcal that are being approved advanced, do you recommend being vaccinated again if you had an earlier formula?
Again, that's a complicated question. If you have had Pneumovax after age 65, and if you lack high need another. If you've had a Pneumovax before age 65, you should get another. And at this stage of the game would be Prevnar 20, but 5 years after the prior Pneumovax. So, but there are some individual clinical circumstances in which you would want to boost it. People who lack a spleen, people who are highly immunosuppressed, people who have severe pulmonary disease. As far as shingles is concerned, the older Zostavax was less effective, probably in the low 80s range. The newer one is effective at about the 94% range. It is not a live vaccine unlike the older one. So if you've had the older shingles vaccine, it's reasonable and generally recommended to get the newer one.
Okay. Well, thank you so much. You gave us a lot to think about, and I really appreciate it. And I'm sorry you couldn't sing your way through the whole conversation.
Well, thanks.
The
Thanks
Wolff
for having me.
family has a whole lot of beautiful singers. So thank you so much for joining us tonight.
Thanks for letting me on. Take care. Happy Thanksgiving.
Yes, happy Thanksgiving. Okay. Our second speaker for tonight is Jane Sanders, who has a master's degree in social work and a certificate in gerontology from Syracuse University. She has spent her career working with older adults, and she now identifies as one herself. Much of work has been in nursing homes, hospitals, and community agencies. Before retiring almost 3 years ago, Jane was the director of the Town of Bethlehem Senior Services Department, where she was employed for 18 years in various positions. Jane now spends many hours each week volunteering in the community, and in her free time, she enjoys biking, canoeing, and playing in the snow. Thank you for joining us tonight, Jane.
Thanks, Debbie. Welcome, everybody. That was very interesting hearing what Dr. Wolff had to say about aging and what we should all be doing. So what I'm going to share my screen, which take a second here, I think. There it is. Huh? All right, good. Okay, what I'm going to be doing tonight is talking to you about MOLST, which is a type of advanced directive. MOLST stands for Medical Orders for Life-Sustaining Treatment. So this is really 3 different parts. So I'll talk about MOLST. I'll talk a little bit about Medicare health insurance, and then FACP, which is Health Insurance Information Counseling Assistance Program. And I think you have a handout as to who is the person in Albany County to contact, but we'll talk about that later. So we'll talk a little about the MOLST form. The MOLST, as I said, is an advanced directive. It is a New York State Department of Health form that people can say whether they want to be resuscitated, intubated, etc. Each form that I talk about tonight, I'm going to mention the healthcare proxy and the community do not resuscitate. Those are all New York State Health Department forms that can be found on their website. So who needs it most? People who want to avoid or receive any or all life-sustaining treatment, people who live in long-term care facilities or require long-term care services at home, and people who might die within 1 year, but who knows when any of us when that's going to happen to any one of us. The MOLST form, excuse me, is a bright pink form on that other slide. It's bright pink because that's what it is, and it's kind of thicker paper, and it goes. You keep it at your home, but you fill it out with your doctor. It has to be completed. You can complete it on your own or look at it, but you discuss it with your doctor. It can be signed by the doctor, a nurse practitioner, or a physician's assistant. There are mainly 2 sections to consider. The first is when there's no pulse and there's no breathing in the person. The thing that you decide on is, would you want CPR or do you want to die naturally and not be resuscitated? So that's one part. The second part is when the patient has a pulse and is breathing. So hopefully this is more of us. You can choose whether you want your treatment guidelines to include comfort measures, limited medical interventions, or no limitations. Comfort measures only would include pain relief, offering food and fluids by mouth, to having your wounds cared for, turning in bed to avoid bed sores, having oxygen or suctioning airways if needed, all things to keep someone comfortable. Limited medical intervention is receiving medication by mouth or through an IV, having your heart monitored, and all other necessary treatment based on your MOLST order. The third is no limitations or no limitations on medical interventions, which means you would receive every kind of treatment that there possibly is out there. In my experience, it's been rare to find people who want everything done to them. often people are realistic when they're near the end of their life. They realize I've had a good life and I don't want to keep living forever, but some people want to, and that's part of why you would fill out this form. If you, so you can decide what you want for your future. So, does the most replace a healthcare proxy? Oh, there's actually a little bit more about most, I'm sorry, to talk about. There's also, you have options for feeding. If you're unable to feed yourself, you can have a tube inserted into your stomach. You can have no IV fluid, everything from a tube to nothing as far as feeding. As you decide on antibiotics, do you want to use antibiotics for comfort care? Do you want to have a limitation on antibiotics? Do you want to be sent to the hospital or cared for at home? So there's many things to think about with the most. The most form is the only New York State authorized form that has both do not resuscitate and do not intubate, having a tube in you, and can be used in the hospital and in the community. Meaning if you're at home and you call 911 and the emergency care comes, if your most form is on the refrigerator and they see it, they'll know not to do certain treatments on you, or to take you to the hospital, not take you to the hospital. So it's a legal form. Okay, then does the most replace a healthcare proxy? No, it does not. The healthcare proxy, which I think you heard about last week somewhat, is a form that anybody can fill out if you're 18 years of age or older. You name someone to make medical decisions on your behalf for if the time comes that you're no longer able to make the decisions on your own. You also have an opportunity to decide if you want to be an organ donor on the healthcare proxy form. There's no lawyer needed. There's no notary public needed. It's a form that was created so that anybody can fill it out. The important things for a healthcare proxy are that you have a discussion, as well as the most too. You have a discussion with your proxy and your alternate to state what your wishes are regarding care, especially with artificial hydration and nutrition. So these are hard forms to fill out. Nobody wants to think about later in life or illnesses, but they're really important to do. I have one. As last week, I think you learned that sometimes lawyers do these forms, which is fine as part of an estate planning, but this can be done by anybody. Thanksgiving's coming. What a perfect time to have a healthcare proxy signing party with your family or your friends. The form really states a lot, is pretty self-explanatory. What you do with the form with a healthcare proxy when it's done is give copies to your doctor, to your family members. You can put one in a file of life if you have it. Do not put it in your safety deposit box, because it's something that you may need at the drop of a hat. The same thing with the most form. You have it at home and you take it with you. If you're going to the hospital or you're moving to another facility, you should. Of how we age, the yellow is healthy and independent. Then we start as we age a little bit, or even if we're younger, people have chronic diseases and some functional decline. Maybe we have arthritis, osteoporosis, heart disease, cholesterol, various things that Dr. Wolff was talking about. And these are, you can see as it goes along, the importance of having why you would need a MOLST or a healthcare proxy. A living will is good too if you don't have someone to name as your decision maker. Switching gears here to Medicare health insurance. You should all realize that this now, if you're 65 or older, you have a Medicare card that looks like this, red, white, and blue card, that you have Medicare. Open enrollment happens every year from October 15th to December 7th. You can change your Medicare coverage. You can have original Medicare, Medicare supplemental plan, or a Medigap plan, or a Medicare Advantage plan, which is usually an HMO, a health maintenance organization. There's two parts of Medicare, Part A and Part B. Part B is the one that costs $170 each month right now. It's going down to $164.90, so not quite $165 next year. People, many people have the fee taken out of their Social Security check, so they don't even really realize that they're paying for it as a benefit. If you have health insurance from a retiree from your former employer, you don't need to listen quite as carefully to the next few minutes. Also, all of this information is available in the Medicare and You booklet. So there's original Medicare, which has a deductible that covers 80% of care. There's no yearly out-of-pocket limit unless you have a supplemental plan. With original Medicare, you need to buy a Part D drug plan. There's Medicare, these are just the options. Medicare Advantage plan has the same benefits of original Medicare, but it does have a yearly limit on out-of-pocket expenses. And it usually includes a drug plan and has extra benefits that add to your quality of life, like vision coverage, hearing aids. Hearing aid doesn't cover them, but it can cover part of the cost of them. Basic dental care like cleanings, x-rays. None of those things are covered by regular Medicare, which I never quite understood why the quality of life things, hearing, seeing, eating, like dental, are not covered. But there's also something called Silver Sneakers, which a lot of people like, which includes going to the JCC or the YMCA membership for free. The Medicare supplemental plan, also called a Medigap, has standardized plans and includes many of the deductibles. It does include foreign travel coverage, some of it. I always think of Medigap as a more comprehensive insurance, and it's very good for people who travel, who spend half the year in one state and half the year in another. There are many different companies that offer Medigap plans. The plans are standardized. So if you have for example, a Medicare K plan, it's the same plan, whether you get it from Humana, whether you get it from Aetna, whether you get it from wherever, but often they charge different amounts. So I think it's wise to do some research before choosing those plans. As well, all the other plans, Medicare Advantage has different ones too, but they're different coverage, whereas the Medigap, it's the same coverage for certain plans. So keep that in mind. There's Medicare Part D, which is for drugs. Prescriptions, you need to get an additional Part D if you have a supplement and you have original Medicare. So that's a little bit of that. A lot of people ask, will Medicare pay for home health aides? Only if you are receiving other skilled care, such as a nurse coming in, skilled nursing, physical therapy, speech and language pathology services, and continuing occupational therapy if you don't need speech or physical therapy or skilled nursing. When Medicare pays for a home health aide, it may be an hour a day, a couple times a week. It's not like it used to be, where there was a time years and years ago that Medicare would cover 3 hours a day, 3 days a week. That doesn't work anymore. So, and the other thing people ask about is nursing home coverage. Medicare will cover for rehabilitation after you have a 3-day admittance to a hospital. If it's deemed necessary and helpful to go to rehab, then Medicare will pay the first 20 days, and then there are co-pays after that for pretty much all of the different insurances. So Medicare does not cover ongoing long-term care. If someone goes to rehab in a nursing home and they're not making the progress that they thought they would, or the family and everyone had hopes for, then they may need to stay on and or get more care at home. But Medicare does not pay for the ongoing long-term care. They say, I heard someone once say, be rich, be poor, or be insured. Long-term care insurance is a whole other topic. So the other thing is, if you're at rehab and they say, come on in, Mary Jo, it's time for you to have your physical therapy, you need to say, okay, yes, I'll do it. If you say no after a certain number of times, you're out of there. There's no need for you to be in rehab if you're not taking advantage of it. Okay, HICAP. This is the other thing. Health insurance, information, counseling, and assistance program. As I said, your health insurance in Part D, you can sign, change it each year from mid-October till December 7th. The different Part D plans, which is prescription, changes year to year. So just because you have Humana this year doesn't mean that same Humana plan will be the right one for you next year. Perhaps some of your drugs have changed, or the coverage in the plan has changed. So it's really important to look to see if it's still there or not. There is the Part D plans kind of make me crazy, because you are paying from $20 to however, maybe over $100 a month just for the privilege of being able to get your drugs from that company, and before you even get the drugs. So if you want to do the review on your own on the Medicare.gov website, it's not too difficult. It would be Medicare.gov and then find health and drug plans, and you just follow the instructions and can compare different plans. If you don't want to do that, you can contact the New York State statewide Senior Action Council. This year, they have the contract for HICAP, for counseling people for health insurance. So you could call that number, that 1-800 number, and I believe you have in the handouts, it's got a little more details of where they're located, and the guy's name is Gene, who you should contact. And so you have that in what you got in the handouts earlier. So there is the New York State EPIC plan that helps pay for prescriptions depending on your income. You can have income up to $100,000 for a couple, $75,000 for an individual for their deductible plan, but the fee plan is for people with incomes up to about $20,000. And it's a great program. If you qualify, your drugs will not cost more than $20 for a 3-month supply if you're taking it once a day, whatever, you can check into it. I set my alarm. It's a good thing to have if you qualify. So EPIC stands for Elderly Prescription Insurance Coverage. So most things I said are in the Medicare and You 2023 for next year, the official government Medicare handbook, or you can look on Medicare.gov to find out more, the same information. So I don't know if you can see this whole thing. This is just a nice picture. I will be ready to take some questions if you have them. And thank you for listening.
Thank you, Jane. I have a question. Can you, from year to year, change back and forth to a pure Medicare only versus one of the Medicare Advantage plans?
Yes, you can do that. If you, yes, if you go back to what's called original Medicare, you can do that. There's certain dates that you can change back, but yes, you can decide not to have a Medicare Advantage plan, or you can have original Medicare and the supplemental. Yeah, every year you can change back and forth, whatever you want to do.
I know it can be very daunting when one starts. Do you have any, I know when I turned 65, I felt my head was spinning and I felt like I needed a PhD in this to work my way through it. Do you have any advice for someone where they can get someone to help explain it in real normal terms so you get your head around it all?
Yes, it is. I just turned 65 last week, and
Happy birthday.
thank you. And to you as well. Yes, it is, can be very, very overwhelming. There are so many options. You can contact one of the local insurance companies like CDPHP and ask them about their plans, and you can go online, or you can go to that, what I was saying before, the New York Statewide Senior Action Council. Talk to someone there. I believe they have counselors that will help you when you're turning 65. Or if you live in the town of Bethlehem, you can go to Bethlehem Senior Services, and I would imagine Colony and Guilderland, the other places, would have someone there to explain things to you as well. There are also often people who speak about the basics of Medicare, and that's a good thing to go to a program like that a few months before you turn 65, so you're aware of some of these options before you hit into it.
So it's sort of never too early to start learning about this and getting your head around all the terms, because it really is a lot.
It is a lot, yes, and it's something I've been doing for years. So for me, it's just what I do. But I understand that this is very abnormal.
So do you, another question, do you have to have Medicare if you're still working at age 65?
No. If you have insurance that's better than Medicare, you can certainly have that. And there's some form that you fill out that's on the Medicare.gov website, or maybe Social Security website, that you, when you do decide to apply for Medicare, it's a form that proves that you had insurance up till then. And the same thing with drug coverage. I believe most companies or HR departments sends a letter saying, I don't know if it says letter of creditable coverage, and it says keep this letter in case until you sign up for Medicare, because you need to prove that you had drug coverage that was as good as or better than a Part D that's available. So yeah, so then you get those from HR usually if you're still working.
Okay, and we have a comment from Roberta, my good friend Roberta, giving some advice. Medicare Solutions LLC can help individuals work their way through the various choices. She doesn't know what they charge, if any. She attended a free seminar presented by them, and it was very informative. Another question, can you only sign up during open enrollment season?
You can sign up other times, but it doesn't, I think at this point, if you, yes, you mean sign up, well, for open enrollment, you mean signing up for, I'm assuming you mean for the supplement or Medicare Advantage. If
I retire, if I have health insurance and I retire in June.
No, then
then when do I apply for Medicare?
Before you retire. So it starts, that's a special enrollment period. And there are lots of SEP, they call it special enrollment periods. So no, you don't want to go uncovered. You don't want to go, my brother-in-law is just retiring and I help them figure out what they might want for health insurance and said, you're retiring December 31st. You want this to begin January 1st. Unless you have COBRA, you don't want to be uncovered for insurance.
Gotcha. Well, thank you. I think we could probably keep you here all night asking questions, but that wouldn't be fair to you or anyone else because we get zoomed out.
All right.
Thank you so much. And I thank you all for joining us tonight for another really important conversation. Please join us next week, November 29th at 7 p.m. for our final program in the series, Preparing for End of Life. Hear about palliative care and hospice service offerings, get a checklist for what needs to be in place when someone dies, as well as advanced funeral preparation and paperwork. Our facilitators will be Caitlin St. George from the Community Hospice, St. Peter's Health Partners Provider Relations Supervisor, and Mark Levine, Levine Memorial Chapel, Director of Levine Memorial Chapel. And finally, please complete the evaluation that we will be sending to you via email. And we also want to wish our sponsors who are listed in our chat box right now. So thank you all for joining us tonight for another really important conversation. Wish you all a very happy and fun-filled, but now I know I have to eat a lighter meal for Thanksgiving. So I have to be mindful of that. So I'll do that, maybe. Take care all.
Thanks,
Good night.
everyone.
Bye-bye.
Good night.